Welcome everyone to the second day of a Reciprocal Innovation Stakeholder meeting. I hope many of you participated yesterday and got a lot out of it. We are happy to have you here today, as well as AMPATH supporters joining as part of our monthly Fireside Chat series. Today, we want to explore the concept of reciprocal innovation in more detail, which is a mutual benefit addressing a shared challenge between the developed world and low and middle income countries, and how it can really strengthen health systems and face the global pandemic. Next slide, please. I'm a longtime member of Indiana University, although I recently took a 5-year sabbatical to be founding chair of the Department of Population Health at the Dell Medical School in Austin, Texas. But I'm back. I'm here now as Associate Dean for Population Health and Health Outcomes for the Fairbanks School of Public Health, as well as a professor in the Department of Global Health in the school. Next slide, please. This is going to be our agenda for this morning. We're going to start off with a keynote address from Roger Glass, and then followed by an interactive panel that's going to be chaired and moderated by Deborahlitzelman. Next slide, please. I also want to mention that give a little bit of background of the AMPATH program. Is a collaboration that began between Indiana University and Moi University in Eldoret, Kenya, back in 1989. And for the first decade or so, it was mainly a bilateral educational exchange between IU and other universities in North America and Moi University, with a little bit of research being done. I think Carol Wools-Kalustian did some work as a fellow back in the early 90s. The first big grant we actually got was in 1998 from the Fogarty International Center. It was a training grant in medical informatics, with which our Kenyan colleagues developed Sub-Saharan Africa's first ambulatory electronic medical record system. That came in handy in 2001 when Joe Mamlin and colleagues, including me, decided that they could no longer stand on the sidelines and jumped into the fray in fighting the AIDS pandemic in Sub-Saharan Africa, launching the academic model providing access to healthcare, or AMPATH. AMPATH has developed into a robust care education research program that involves more than 15 North American universities and is rooted in a mission to first lead with care, and not just healthcare, but care and caring for patients in a holistic manner, equity, participants. AMPATH are often brought back to places like Indiana and the other states in which the other AMPATH schools are situated. Next slide, please. The important principles of reciprocal innovation are that there are things that we can learn in low and middle income countries that have relevance in both urban and rural America. And so it's not just philanthropy, or it's not just being nice to people in low and middle income countries. We learn things that can benefit us and the people we serve. So there has to be mutual benefit. The partnerships have to be equitable, and there must be continuous learning and innovation throughout the collaboration. So that's why we're here today, to discuss reciprocal innovation. Next slide, please. And to kick that off, I am really pleased to introduce Roger Glass. Roger Glass is the director of the Fogarty International Center at NIH, and is also the associate director of international research at NIH. He received his AB and MD and MPH degrees from Harvard and completed a PhD from the University of Gothenburg in microbiology. In '77, he joined CDC's epidemiology program and spent 4 years working on cholera vaccine development and enteric disease research at the International Diarrhea Research Institute in Bangladesh. So he doesn't just fund international research, he has jumped into it with both feet. He went to NIH to pursue research on rotavirus, the most common cause of childhood deaths and hospitalizations from gastroenteritis worldwide. And if you look up his citations, he has more than 1,000 citations for half a dozen articles on the rotavirus. He returned to CDC to build the viral GI group that developed data on the burden of disease from rotavirus that served as the basis to include vaccination for all in the US as well as globally. During his leadership in the viral GI group, he trained scientists from more than 50 countries in rotavirus research and developed 2 licensed vaccines. In 2006, he was recruited to help expand programs in global health. He has authored more than 600 publications, is a member of the US National Academy of Medicine, and has received the Pasteur Award of the Children's Vaccine Initiative, the CBC's Charles Shepherd Lifetime Achievement Award, and the Director's Award for Innovation, the Sabin Gold Medal Award in Vaccinology, and the NFID's Charles Milieu Award, and Jimmy and Rosalind Carter Humanitarian Award, and finally, Research America's Godfrey Benning Builders of Science Award. Roger's a friend of AMPATH, and I'm excited that he's going to be kicking off our conference today as the keynote speaker. Roger?
Thank you, Bill, for that lovely introduction. And I'm delighted to be here. Let me share my screen, if I may. Share. Yes, I'm really delighted to be here. And I have to tell you that I'm here because of a very interesting trip I took some time ago. And if my screen advances, let me give it a second. Not advancing, what's wrong? Okay, be that way. Let me stop and try another screen here. Let me try to share it again. This one. Little glitch. Okay. Well, it must have been about 12 years ago. I was in Bellagio, Italy, in this beautiful location at a Rockefeller resort, and I went jogging in the morning, and I met at jogging Bill Tierney, who I hadn't met before. And in that jog, he talked and I listened, and he told me about PATH, about the Indiana program. And I was so fascinated that I put him on the advisory board of Fogarty so I could learn more and get some of his insights into what AMPATH had been doing. With that, with him there, I was encouraged to bring Dr. Collins, an NIH director, to Eldoret to see what you were doing, where he met, you see there, Joe Mamlin and many of your staff, and he spent the day there, and he was blown away by the people he saw, the programs, and the innovation. It was so interesting that I went back in 2019 with 2 of the newest directors of the Institute of Child Health and Human Development, Diana Bianchi, right there in the front on your left, and Josh Gordon, the head of the director of the National Institute of Mental Health, along with Steve Reynolds from NIAID. So we had a group visit, and you'd say, well, why would they want to visit? There were new institute directors. They each had more than 25 grants that they had never seen of why they should be investing in Kenya. And this was their first chance to see them. And they both came away as advocates and enthusiastic by what they saw. You can see Sylvester there and Jerry Bloomfield, who was a Fogarty Fellow, who's now an associate professor, still working at AMPATH and building his team. Well, I learned all of the lessons that Bill mentioned about the importance of AMPATH, that open MRS that Fogarty funded in our first informatics grant, the academic model, the teaching, even taking people from all walks of biomedical science, like pharmacy. And I remember meeting your pharmacist from Purdue, who was so excited about delivery and the logistics of drugs for antiretroviral drugs for patients with HIV, but moving on to antihypertensive drugs. And he told me that being at AMPATH was his dream job. So it was exciting. When I first got to Fogarty, I got called down to Congress by a congressman from rural Washington, who asked me the question. He said, why should we be investing in global health research at all? There's so many demands for funds at home. My people are loggers who are unemployed in rural Washington. What's in it for us? What can be of value for this? And you have 10 minutes because I got to make a plane. Well, young director, what would you say to that question? What can we learn and what's of value to us at home? Reciprocal innovation. Don't we have to take care of our own populations first? Well, of course, the traditional idea is that we do global health because there are unique populations, unique genetic backgrounds, exposures. We can learn about healthcare delivery, but there are new approaches needed to reach our global partners' health goals, and many of these will find use at home. So from there, as Bill said, I cut my teeth by working in Bangladesh on cholera. And that was my first introduction to reciprocal innovation. And I said to the congressman, I said, Congressman, do you have any children in your constituency up there in rural Washington who have diarrheal disease? Because we know nationally that 12% of hospitalizations for children are for diarrhea. Do you know where their treatment came from? And of course, he didn't have a clue. And I said, well, I was in Bangladesh where cholera was the most severe form of diarrhea. And here you see a patient who survived with 98 liters of intravenous fluid. But you can't use intravenous fluid in rural Bangladesh. You don't have IVs or the equipment. What could you do to provide care for those children who would die of diarrhea otherwise? And that led to the development of oral rehydration solutions and oral rehydration therapy. The idea that this research developed a solution of salts and sugar could allow children to be rehydrated at the same time that they were purging from cholera. And this was credited by Lancet as one of the greatest medical achievements of the 20th century, a gift of science to all. So I said, Congressman, the treatment that you have in Washington came from research, less than $10 million of research in Bangladesh. It's been huge. And in fact, the two people who conducted the trial were NIH fellows in 1968 in the Office of Global Health, which became the Fogarty International Center. So they were probably our first two Fogarty fellows. Well, I came back home and realized that when I went around the world and I spoke about diarrheal disease treatment and the impact of oral rehydration solution, we had no recommendations for this in the United States. And so with CDC, we wrote the recommendations for the treatment of acute diarrhea for children, and it was based on that research in Bangladesh. Oral rehydration therapy industry now reaps more than $100 million a year, a return on that investment that's huge and is used right in rural Washington where your constituents live. But let's go on to some other examples. So when I first got to NIH, there were very few of the institutes that had a real portfolio in global health. Certainly infectious diseases, some cancer, and some child health, but not a lot. So we had a session with the director. We said, let's everyone talk about why they might be interested in global health. Well, Tony Fauci spoke first, an easy sell for Tony, because we know, as we've seen with COVID, that a virus emerging in China can affect the entire world. And we've had multiple epidemics. We have to be global in our perspective and train people for early detection and developing protection for the American public. So we really have to be global there. But how about cancer? Well, cancers are different in different parts of the world. And if you just look in Africa, that Burkett's lymphoma was a unique cancer to Africa. In fact, John Niederhuber, the then head of NCI, said 85% of cancers in the world are in low and middle income countries. We have to learn about these cancers where they occur. And in fact, it was an NIH grant to Dennis Burkett, who at the Uganda Cancer Research Institute at Mulago Hospital, who was the first person to link cancer with a virus, Epstein-Barr virus. And now we know we have HPV and papillomavirus, cervical cancer, hepatomas with hepatitis B. So I said, Congressman, do you have any patients with cancer in your constituency? And he said, of course we do. I said, do you know that the link between viruses and cancer was discovered in Uganda by Dennis Burkett? And that's been the seed for what's come afterwards. He said, no, I didn't. I said, now how about chemotherapy? The first successful chemotherapy came when Dennis Burkett put some antimitotic agents from Sloan Kettering into his pocket, took him home and treated this young boy with lymphoma of the cheek. And in 2 weeks, that treatment was successful, a real boost and the first successful chemotherapy for lymphoma. So, Congressman, we've learned about the treatment of lymphomas in your constituency from this early work on chemotherapy. But also, there are big questions in cancer control. For instance, in Rwanda, could you stop cervical cancer deaths in a country, an African country, so poor but well organized? And here you see Agnes Binagwaho, the Minister of Health of Rwanda, who was able to negotiate with Merck for an HPV donation of vaccines. She said, our country can't pay the prices you want, but we will guarantee you that 90% of our girls would be immunized, and you can use Rwanda as a base to see if we can actually eliminate cervical cancer in women, or if new strains arise and we need new vaccines, we can help you with that research. Reciprocal innovation. How about in Costa Rica, where the Minister of Health said, we can't afford HPV vaccines and giving 3 doses or 2 doses to our girls. Could we get by with a single dose? And sure enough, with help from NIH and the Gates Foundation, they looked and they found evidence that single dose protection by this HPV vaccine was successful. Another way that we could improve care at home and decrease the cost of care and the access to HPV vaccines globally through global health research. Well, genetic disorders, at that time, Francis Collins was head of the Genome Institute, and he said that the US is a melting pot of our genomes. People from all over the country, all over the world have brought their genes to America. So it's easier for us to work with many genetic diseases by going to founder populations. So I said, Congressman, do you have any patients with Alzheimer's up there in rural Washington? It's going to be the main cause of economic cost for healthcare in the future as our populations age. He said, well, it is a problem. I said, you know that we're finding some of the most interesting research in Colombia, where this family of descendants of a woman who migrated from Europe to Colombia around 1746 brought the gene with her, a PISHA2 mutation, and spread that through a whole cohort in her community. That community now has been able to let us look at the genetics of Alzheimer's, to look at biomarkers for progression of this unique disease, which has early age at presentation and rapid progression. We are doing clinical trials in Colombia on this disease, which would be much more difficult to do at home. And this will be helping both them and us. It's a way to accelerate our own research. So global health for your community. And of course, environmental disasters, it's the same story. We can learn a lot from environmental problems around the world. Well, Fogarty is the smallest of the 27 institutes at NIH, and we have a mandate specifically for global health. But we work with all of the other institutes to get them engaged in the global health agenda. Our aim is to address global health challenges through collaborative programs of research and training, and to support the NIH mission. So 88% of our grants from Fogarty are co-funded by the other institutes at NIH. And our strategy is to build research capacity of individuals, institutions, and networks, to stimulate innovation and new ideas, to support implementation science, to recognize the dual burden of communicable and non-communicable diseases, and to strengthen partnerships. So here we are, and we have a whole portfolio of grants of different sorts, from the infectious diseases, chronic diseases, mental health, implementation science, and now data science and innovation. It's a wide portfolio, and we've trained literally thousands of people in the developing countries and at home. We have a whole portfolio of different grants to follow people for their careers, and individual grants for foreign investigators, getting a K award, and that we share with many of the other institutes. So it's a part of our endeavor is building that health workforce. When Dr. Collins became the director of NIH, I was really concerned that someone who was such a basic scientist would take global health seriously. But when he wrote his mandate in Science, he said that his fourth mission as director would be to expand research into diseases affecting the developing world. And I scratched my head and I said, why is he interested in this? What was his motivation? When he was a young attending in Michigan, he went to Nigeria and worked at a rural hospital as a physician, as a young professor, assistant professor. And he found patients who were thin, who had diabetes. And he never thought of this as a type of diabetes, a presentation. So he's started his own research lab, which is still today working on the genetics of diabetes. And it came from this experience of finding the first genes of diabetes from these patients in Nigeria. And he's still enthusiastic, passionate about working in global health. Well, we've spoken already about COVID and how that's affected our lives. And it's clear that there's no country in the world that doesn't see the value of global health research today for their own survival, for their own biosecurity. We can also see how outbreaks that have occurred spread to countries and what measures we need to take care of them. So Fogarty's been deeply involved in this response to COVID, the global response to COVID. How have we done this? Well, I think our biggest contribution has been through the people we've trained over the years, many of them in HIV research, learning about prevention, learning about vaccines and drug development. And you can see here people like John and Kangasan running the Africa CDC, who is a Fogarty trainee in epidemiology and lab science, or Zunyu Wu in China, who is a former fellow and is at the heart of China's COVID response. So I think our biggest impact has been on the people we've trained before. But we've also seen and are working now in getting genetics epidemiology training around the world to laboratories so they can look at their own COVID sequences and strain variants. And this has only been possible because of these advances like this Minion platform where you can do a sequence of a COVID strain in a half a day for under $50 in a rural laboratory. That change has allowed training to occur. And so our group at Fogarty is working on this training activities. Now, in AIDS, and I can ask that congressman if he has any patients with AIDS in his constituency, because many of the research breakthroughs have come from our AIDS international training and research programs, and many of those advances from Africa, from understanding circumcision as a means of prevention and programs that have been adopted, to drug therapies, to prevention of mother to child transmission of the virus. It's been impactful that AIDS Fogarty trainees have been involved in almost every major breakthrough. When we were in Uganda with Dr. Collins, he found these three women whose story tells it all. The young woman on the left was a graduate in electrical engineering. Born with HIV, she went through 7 clinical trials to go from taking 18 pills a day as an infant to taking 1 pill a day as an adult and having a normal life expectancy. The woman in the next to Dr. Collins in blue was a woman who found she was HIV at the delivery of her first child. She entered into a prevention of maternal to child transmission study. Her child came out HIV negative. She married an HIV negative man, another man, and had 2 healthy children. Her life had been changed through research. And the third woman was in the PrEP trials, worried about her own safety. And PrEP, each of these women have contributed to trials that have affected how we deal with HIV in the United States, seminal events in reciprocal innovation. Well, each year, one of the joys of my job is to send about 100 fellows and scholars, both US and foreign, for a year of mentored research in an institute in a low and middle income country. And about 75 to 80% of them come back enthusiastic about pursuing some research in global health. It's been an impactful program for us. And at AMPATH, you've had almost a dozen fellows from this program who have gone out following in the tracks of Jerry Bloomfield. Here's Jerry, who was a fellow with us more than a decade ago. People thought when he went and wanted to do cardiology in Kenya, he was wasting a good career at Duke. But Duke had a global health program. He's now an associate professor of medicine and global health. He's had K awards. He's got other NIH awards, and this really launched his career. It not only launched his career, it changed his career in Eldoret. Because he was able to get Duke funds to support and build a cardiac care unit for research. He had other trainees from other institutions who have gone to Eldoret to train in cardiology. He has a training program in cardiology, I believe the first in Kenya. And he's got a Duke, a retiring professor of cardiology there as a mentor brought in. So he's really built Eldoret into a center of excellence in cardiology and cardiology research. Wonderful addition from AMPATH, Reciprocal Innovation. Rocky Otang, Ghanaian born in the United States, went to Ghana to work on emergency medicine. And what he's learning about road traffic injuries and trauma, he's bringing back to the University of Michigan, lessons taken home by working in an area where there's no legacy program for trauma and for emergency medicine. Here, a cardiology fellow in pediatrics went to Malawi to study congenital heart disease, rheumatic heart disease, and she brought with her the first sonogram, essential for a cardiologist. She's gone back to set up a cardiology program. She has an academic position at Baylor, and she has a new Fogarty Award for 5 years to work on the elimination and control of rheumatic fever in Malawi. A big plan in a country, in a world where we still have 300,000 deaths from rheumatic heart disease, where we have possibilities to use bicillin for treatment, screening for strep throats, and the ability to use catheters to replace valves that would otherwise need expensive cardiac surgery. So she really has a 30-year vision. It started from her Fogarty Fellowship, just like Jerry Bloomfield. Mobile health technology is new in the United States, and it's been easy to get groups in the developing world to work on this because in places like Kenya, most of the banking is done by cell phones and smartphones. So there's a whole effort that we have at Fogarty with many of the other institutes to work on mobile health and telemedicine. And this has come to the fore in the COVID period when many Americans cannot go to visit their physicians, but where telemedicine has been more widely used. Just as an example here, Bob Bollinger, who is also on our board at Fogarty, used his work in Uganda on following and tracking patients to monitor patients in the United States in the opioid epidemic. And this research that was conducted and is used in Uganda is now used by a small company on opioid monitoring of patients. Another project to improve health in Uganda that's returned its investment in the US. Antiretroviral monitoring in Uganda, another clear and wonderful use of cell phone technology. Drones in Rwanda to deliver blood to women hemorrhaging in childbirth. They can deliver 2 units of blood to district hospitals 40 kilometers away in 15 minutes, quicker than it takes to get blood from the basement blood bank of an urban hospital to the patient's bedside. It's quite remarkable. And here you see the drones, a US company from California working with President Kagame, who said, why don't you start by delivering blood for a pregnancy and to prevent maternal mortality? Also possible first in Rwanda, because there are no legacy settings. There's no FAA regulations of where you can fly. They didn't need to pass the regulations. They identify each flight that's going, but it's been accepted by the president and on down. More than 100 deliveries a day. And here's the first woman whose baby was successfully delivered and she received blood from the Zipline project. Zipline is now used in Baltimore to deliver organs for transplant within the city because it's easier to put them into a drone and send them across the city than it is to put them in ground transportation. And finally, for mental health, here's Dixon Shibanda, one of the few psychiatrists in Rwanda who tried to figure out how to make low-cost mental health available at a time when the DALYs for mental health are second only to infectious diseases in that country. Here, he developed the idea of a friendship bench, training elderly women to sit down and do a structured interview, 6 structured interviews over a period of time with people with problems. That idea is now being used in New York and in other cities, friendship benches. And here you see it's used in New York. I thought that was an amazing advance. So we've learned a lot about global health that's reciprocal. And for young people, we've learned that these field experiences both ways, foreigners in the US and our people abroad, can provide a unique education. Also, if you start with young professionals, they're really idealistic, they can change the world, and those investments in early childhood education, early career education, can pay dividends throughout life. Takes a long time. Solutions have to be multidisciplinary. Partnerships are essential. Mentoring is critical, but we have to take science where the problems are, because the frontiers of science may not be at home. Well, here I have to go back to Indiana. I was delighted to see Deborahlitzelman is with you today. Here she is with the Surgeon General. She's one who's clearly followed this mantra of bringing back ideas from your overseas experience to your own backyard. And there are quite a number of these. So, and Bob Eintertz in the photo also was a member of our Fogarty board. Amazing young physicians, researchers bringing lessons back home. So the values of global health activities at academic centers is huge. It's the best way to recruit young people before they're vested in a strict career with children and families. It's good to get them young. They're open to ideas, they're idealistic, they recognize and have unusual skills, and it really broadens their perspectives on creativity, thinking the way other people think and finding solutions. I just want to add with 2 advertisements about Fogarty. One is that we host the website worldreport.nih.gov. And you can go to this website and it has data from 12 funding agencies, over 400,000 program records of the major funders around the world of global health research. And when I went to this and I put in for the year 2019-2020, Kenya for NIH and Eldoret, I pushed the button of search and I came up with this report. And it has all the grants that NIH has funded in Eldoret over the past 2 years. It gives the titles, the investigators, the collaborators, down to the collaborators off the screen and the abstracts. So AMPATH has done incredibly well. I believe it's over $130 million of NIH grants and more, but also all these collaborations which aren't fully counted. So this is a nice way for you to see what you're doing. And you can see the top grant is on severe mental illness and genetics in Eldoret. It's part of a global study, but this is one of the reasons that the head of the Institute of Mental Health ended up in Eldoret. We've also spoken about decolonizing global health, the issue of equity. I never liked the term decolonization, but the Africans were colonized and decolonization is part of their vocabulary. For us, we think about equity or democratization as a better term, and it's something that concerns us at Fogarty, that we have equal partnerships in our grants. So just ending with the congressman, we've learned a lot from our global health. For children with diarrhea, for cancer, for keeping the world safe from infectious diseases, for all sorts of reasons, Alzheimer's, genetic studies, the like. The frontiers of discovery and the control of preventive diseases is really likely to take place in the least likely places. We've learned a lot. So for those of you interested in funding and what we fund, we support on the Fogarty website all of the international grants and funding opportunities from NIH. So you'll see them first here at this website and sign up to our Global Health Matters. It now reaches over 80,000 readers. It's huge. Well, here's a picture of Francis Collins with the leadership in AMPATH on his visit. But he not only met with the leadership, but he's really interested in the next generation of people. And he's incredibly, he's an icon and always likes to engage. And it's been wonderful to work with him. He will be stepping down, but he will be at NIH going back to his laboratory at the beginning of next year. I'm here because these three characters have all been part of my own career. They've all been involved with the Fogarty board. Bill initially, Bob Einhertz just stepped down, and Chandy John, who was in Minnesota when he was recruited, somehow has ended up in Indiana. So I have to thank you, a shout out for you, and I appreciate the opportunity to talk to you and to have this fireside chat. So with that, I'll end my talk and open it up to the discussion.
Thanks so much, Roger. Can you all hear me?
Yes, I hear you well.
Okay. I guess there's my video. Okay. We have actually some time. We've got about 20 minutes for a Q&A. And so if you have questions, please put them in the Q&A and I will mediate them. I'm going to start off with one of my own, Roger. The examples you gave were the things that in the past have really been have wreaked terrible havoc in the developing world. Things like infectious diseases, cancer, environmental disasters, and things like that. But as their economies develop, they're developing Western diseases, most of which are the chronic cardiopulmonary, arthritic, psychosocial diseases that we have in the developed world. Can you speak a little bit about chronic non-communicative diseases and the opportunities for reciprocal innovation in that sphere?
Yeah, good question. I think part of my challenge, Bill, over the last 15 years has been getting all the other institutes involved in global health agenda. So now Heart, Lung, and Blood is deeply involved. The Environmental Institute, the new Institute of Bioimaging and Bioengineering. We have a $75 million program in data science and innovation, thinking about how to get innovation in healthcare delivery and data programs, how to use the data we have. The chronic diseases are clearly important. And I was delighted in Eldoret to meet the pharmacist who was taking what he's learned to deliver antiretroviral drugs and put into his pharmacy antihypertensive drugs, and working with the Global Alliance for Chronic Disease to get a program for chronic disease. And we've worked with that group to have international funders work in this space. Mental health, we've got Josh Gordon as a very strong enthusiast for the global health agenda for mental health. And so he has programs all over the world. We have a program at Fogarty that's called Brain Across the Lifespan, diseases from neonatal problems and infections to stroke, aging, cysticercosis, malaria, all TB, all manners of brain disease, and congenital brain disease, Huntington's and Alzheimer's. From that grant that started about 18 years ago, we have 9 of the neuroscience institutes at NIH that have invested. Fogarty put out 160 R21 baby grants, crumbs. The major institutes have come through with over 60 R01s and major grants. And so now there's a neurologic center in Zambia that's had about eight neuro fellows going there, training their fellows. We've had our first neurosurgeons going to Zambia to think about neural tube defects and their treatment with novel approaches that were developed in Uganda and are now used in the US. So we're doing a lot in the chronic diseases now. Life expectancy of Africans is approaching 65 to 70 in some countries. So the chronic diseases are important. Countries realize this. and it is happening. And if you look in that website, World Report, you'll see how much these investments from other institutes has changed over the years. It's an amazing difference. Issue now is to get them to turn over first authorships and to be truly equitable. Because when NHLBI put out its first grant for global health centers in cardiology, one of our star researchers said, this is great that the grant goes to the Africans, but my chief of cardiology will say, no, you have to bring in your own grants. And if you're a subcontractor, it doesn't count. So we have to get equity in dual principal investigators. We have to change the way we do that. And in our last half a dozen years or more with MEPI, since the MEPI grant, we've had more grants directly to the foreign investigators with US subcontractors. And that's been a real difference. This data science initiative, 75 million, is going to foreign investigators who then can contract with US investigators to sustain those partnerships. It's a big change.
That's terrific. We do have some questions in the Q&A. So first is from Debbie Unger, and she asks, what is your advice on how we simply communicate the importance of global health work for our US communities?
I think that community engagement is really important, because global health really touches the heartstrings of everyone. I mean, we all believe in global health. Having community groups engaged, it used to be in the State Department, the city to city programs to bring leaders from one city to another. It's being able to tell your stories. I think the biggest help for us at Fogarty has been to have a newsletter that we put out bi-monthly with good stories of how global health has helped people at home, highlighting either training opportunities, discoveries, things that have come back home, like some of the examples I gave you. AMPATH has wonderful stories to tell. And I think I always remember Bill telling me how the AIDS interventions that you used and developed in Kenya are being used in Indiana. Deborah's work on child health, bringing ideas from the developing world back home. So I think there's a lot we can learn, but you have to advertise that and get the community's involvement.
Storytelling is sometimes as important as data.
Yes,
I think that's true. A second question is from Jim Cleary. He says, the notion of decolonization is very interesting. He's interested in your thoughts on implementing palliative care in Africa in a way that is designed for high-income countries, especially with the concept of family and family care.
Yeah, palliative care has been a priority of NCI for a long time, and they have a whole program on palliative care. And they are trying to move this globally. How can we influence that? My greatest influence in that is now that we had a Fogarty fellow, Satish Gopal, who went to Malawi about 10 years ago as a Fogarty fellow in oncology. He stayed there for 7 years. He brought in fellows in surgery, in pathology, trained local people in pathology, laboratory science. And he did such an amazing job with their center and their laboratory in Malawi that the country put the new National Cancer Hospital right next to the University of North Carolina's laboratory, because they would have that expertise in oncology, surgery, epidemiology, infectious disease pathology, all right there. Satish is now the head of the NCI's Global Health Institute. He's someone who's been there, done that, and understands it. So Satish is the person who understands the palliative care and will be the person who acts on this. But to have a partner who was a Fogarty Fellow, now in leadership in NHLB, in cancer, NCI, is huge. It will change the way things are done. We need to have more people in chronic disease areas on the boards, the advisory boards, stating that this is an important issue.
Thanks. Next question is from Chandy John. He felt that the examples of reciprocal innovation throughout history were amazing, especially the first ones you did on oral rehydration therapy. What advice do you have for those who learn things in the low and middle income countries that we could benefit from in the US in terms of getting them into public health practice? For example, in low and middle income countries, community health workers play a major role in improving healthcare. So how do you think we can work to get public health systems here in the US on board with this and to get financial support to do it?
Well, a great question. My son just had a baby. His wife had a baby in Germany. The first day his wife came home, there was a public health nurse who came to visit the baby for the first week of the baby's life, teaching her how to breastfeed, how to take care of herself, how to feed the baby, all those idiosyncrasies of dealing with a newborn. In the United States, we don't do the same. But in many developing countries, you have a group of health workers around. It's hard. We have to change. We're very structured in health. You can only get to be a doctor by going to a medical school. There are lots of clinical workers who are absolutely essential to the healthcare system. If we can empower them, we'll never have enough psychiatrists. If we can empower those mental health workers with a salary, with a respectable job, I think it'll come. It's a great question, Chandy, and you'll have to bring that up at the board when we next meet so we can thrash it through. I don't have good answers now, but clearly it's the community health workers who are delivering most of the care, and we can empower them with mobile devices and the ability to do so much of pediatric care, knowing when to bring people for immunizations or to deliver immunizations. I think the mobile platform can empower healthcare workers in ways that we never imagined. Good question. I don't have a clear answer for that now, but I think through this leadership training, we can do a lot.
Yeah, it has to do with funding of healthcare and how we can include people who are not part of the traditional healthcare team and get them funded. But it takes evidence, I believe, to people have to be convinced that there's going to be a return on that investment. I think that's where this research comes in. Yeah. We have another question from an anonymous attendee who says, what lessons have you learned from years of experience working on infectious diseases in other countries that helped and are helping the U.S. Dealing with the COVID-19 pandemic?
But lessons from the chronic disease? I didn't.
No, from years of experience working with infectious diseases in low middle income countries. What things did we learn that we could pull out of the toolbox when we got hit with COVID-19?
Well, I was just reviewing this, and when we look back at the Spanish flu of 1918, and you look at the preventive measures that they used then, they used masking, social distancing, hand washing. Quarantine was an idea with cholera, not letting people come into the country, restricting travel. And I was so amazed that some countries have done and put these measures in place effectively and early on. So that's one thing I think we've learned. When this began, we had no vaccines, no drugs. We had no special knowledge of COVID. The other thing that we've learned is that research can really provide answers. I think the biggest thing that happened that was helpful for COVID was the massive investment in research, in getting vaccines, warp speed, $18 billion to develop a vaccine within a year for a disease we had never seen before, but had some experience with. Getting drugs and doing clinical trials that were done internationally to test interventions that we thought might work, like monoclonals, like some of these antivirals, or suggestions of hydroxychloroquine, which didn't work, but we had to disprove so that people would not use it. So I think we've learned through the clinical trials network, we've learned through the research networks, we've learned through research that's been ongoing about mRNA, structural virology, how to make a vaccine based upon experience with SARS that came before, for which SARS and MERS, where people thought of making a vaccine, but the funding was stopped. But a lot of the background, the baseline was done.
In the 5 minutes we have left, we have two additional questions. The first is from Adrian Gardner, who is the executive director of AMPATH. And he says correctly that there's insufficient funding for institutional research infrastructure in low resource settings, which undermines the goal to achieve equity. What can we do to improve that?
Yeah, that's absolutely true. And in many cases, NIH will not fund buildings, for instance, although we can fund equipment. Some people have been very creative in that. If they need to refurbish a clinic or a building, they found workarounds. We see some of this as being a partnership with governments. If anything, the COVID outbreak has let all governments know that they need to invest more. There are some funds available for infrastructure from the development banks, from the World Bank, African Development Bank. So I don't have a good, USAID funds infrastructure. There are groups that do fund infrastructure, but there clearly there's never enough.
Yeah. I guess I will voice a little bit of a complaint, is that the limit of the indirects at 8% is a problem, because that often means the developing country institutions are actually supporting the research.
That is a problem we're discussing right now in our thinking about decolonization and trying to make that more equitable. It's a heavy lift for us because of Congress, but we feel it and we sense it and we would like to do something. I can only tell you that's under active discussion.
That's great to hear.
And we don't know if we can do it. We have to get the key stakeholders on board, and this is a lift for us.
The final question is from an anonymous attendee, but it says, "Thank you for highlighting the work of fellows. Can you elaborate more on those opportunities at Fogarty?"
Oh yeah, I would tell you to go to the website and look at the programs. They're all clearly outlined. The project officers can give you all the specifics, and their phone numbers and email addresses are there. The fellows, I mean, when I started, that was a program for about 25 US and 25 foreign medical students. Now we have over 100, and it includes the fellows in any area of biomedical science. So we've had geneticists and engineers and epidemiologists and dentists, an ophthalmologist and dermatologist, all specialties. So it's an open book. We also partner with the Fulbright program to have the Fulbright Fogarty program for medical students. And that's been terrific. You can get into those programs from any of the grantee sites. They're open to all. So just go on the website and talk to the project officers.
Well, I know I'm speaking for everyone here, Roger. Just thank you for a wonderful presentation and taking the time to be with us today. This has been terrific, and I'm sure you made a bunch of Hoosier friends this morning, and from around the country. It's not just folks from Indiana on the meeting today. But thank you so much for being there and giving us a great kickoff keynote presentation today.
Bill, thank you for the opportunity. And it was you jogging with me in Bellagio about a dozen years ago that really got me involved with AMPATH and with Indiana and the amazing programs that you've constructed there. I'm very proud of what you're doing, and we appreciate your input.
Remember, we were jogging uphill too.
You were talking.
Yeah. Okay. I'm now going to pass it over to Deborahlitzelman, who's going to lead our interactive panel that will take up the rest of the morning between now and 10 o'clock. Deb?
Thank you so much, Bill. And again, my thanks also to Dr. Glass. That was very inspiring and a great kickoff for our morning here with the panel members. So first of all, I'll introduce myself briefly, but then I'm going to ask each of the panel members to introduce themselves. And we'll go through just a series of questions directed at the panelists for their general reactions to Dr. Glass's inspiring talk, and then to talk a little bit about their specific work in global health research. So first of all, about who I am, Deborahlitzelman. I am the Director of Education at the IU Center for Global Health, Professor of Medicine, D. Craig Brader Chair, D. Craig Brader had spent a lot of time himself in Kenya and very dedicated to the global health mission. So quite an honor to hold his name in that position. And I also am a health services researcher at the Regenstrief Institute, where I've had a long career of working in behavioral change and health systems change under the esteemed tutelage of Bill Tierney. So we are a large family. So I will turn to Caitlin, Dr. Caitlin Kelly, to introduce herself.
Good morning to everyone in the US. Good afternoon to everyone over here in Kenya. My name is Catherine Kelly, and I'm faculty with Indiana University in the Department of Medicine. And I've been based in Eldoret, Kenya, working with the empath program for the last 2 years, primarily working with the empath population health team in health system strengthening.
Great, thank you. And we'll go to Megan McHenry, Dr. McHenry.
Yes, thank you. It's so nice to be here with you all today. My name is Megan McHenry. I'm a pediatrician and a researcher at Indiana University in the Department of Pediatrics. I've been working within empath since I was a medical student in 2011. And the work that I do with empath now is focused on neurodevelopment in children born to mothers living with HIV. I partner with pediatricians, Dr. Erin Ayungu on the ground there. So thank you.
Wonderful. And Dr. Kowa.
Good morning, everyone, and good afternoon, evening to everyone else who is outside of US. My name is Edith Koba. I'm a consultant psychiatrist at Moi Teaching and Referral Hospital in Eldoret, where I also head mental health in the hospital. And I see myself as a teacher, as a researcher, and as a clinician. Thank you.
Wonderful. Well, thanks for the panelists for joining us this morning, each in their own right, doing amazing research, global health reciprocal innovation research in the areas of internal medicine, pediatrics, and mental health. So we have a nice broad swath. But I'll start with very general questions and maybe just go in that order or pop-ups if you prefer, but just general reactions or takeaway from Dr. Glass's last hour of information and insight shared with us. So maybe start with you, Dr. Kelly.
Still trying to find the mute after a year and a half of this. Yeah, thank you so much for that presentation, Dr. Glass. I know I learned a lot sort of about the historical context of the Fogarty program and a lot of the major innovations and ways that the research and the Fogarty program at NIH has supported major changes and benefits for health in the US as well as around the world. So thank you for that. I guess the part that sort of struck me was just the part at the end about continuing challenges with global health equity. And I think for me, being here in Kenya during most of the pandemic, to me, that still seems like the major challenge that we have to continue to work towards as partners, as the NIH and as Americans, to really advocate for improved equity, especially thinking about COVID-19 and the vaccines. Here we are a year and a half into the pandemic, and we see the US and wealthy nations getting booster third doses of vaccines. And over here in Kenya and low and middle income countries, we're still looking at only 2 to 3% of vaccine coverage. due to inability to purchase it, inability to manufacture it. And so to me, I think continuing to think about how we address the systems and the policies that continue to allow these inequalities to exist worldwide is the main challenge I'd like to see us focused on moving forward.
Thank you.
I think that again, I echo what Dr. Kelly had said, and it was a fantastic talk. And I personally learned a lot about how the international work that we've done in research has really informed so much of what we did. I knew that generally, but getting so many really excellent examples of that was fantastic to hear. And I'll also agree that, while there are a lot of interesting points that came up in Dr. Glass's talk, I really appreciate in general the advocacy that Fogarty has done in general for global health work within, within Congress, within the NIH, and partnering with so many other institutes to be able to really support the work there, and even thinking through and listening to concerns with equity within like the indirects for funding research and all of those things, and working towards improving equity in the infrastructure of research too, I think was really refreshing to hear. And I'm really grateful for all of the efforts that Fogarty has done in that way.
I think for me, one of the exciting things just listening to him talk is knowing that you can start small and grow. I was a fellow in 2015, 2016, Fogarty, and to see that people can start there and grow and become senior professors, I think that's very exciting. Of course, it's very nice to hear you keep repeating issues of mental health, because that's where I work. And I think one of the things for me is patience. I remember there was a slide I even took a photo of that I found very exciting, that you need to be patient. You don't start with big things, you keep growing. That's very important. And the point where he mentioned that learning starts from the least expected places. So just being open to learn. And of course, the networks, including just meeting someone when he's jogging, the importance of networking and how that can turn out to be really big stuff. Yeah, that for me was the take-home message.
Great, thank you. So just another general question about how the pandemic itself may have changed our views and approaches to future work in global health.
Thanks, Deb. I mean, I think probably from my perspective, the main thing is the difficulty it's caused in in-person exchange. And so for researchers, faculty, trainees, students, to be able to travel in the context of a pandemic has really changed, I think, the way a lot of us work and engage internationally. And obviously, I think there's been opportunity created with, increased availability and accessibility of using Zoom or electronic platforms for collaboration, yet also recognizing that there's limitations and challenges with that, and trying to figure out what's the right middle ground for collaboration moving forward that uses resources in the best way, and also still fosters relationship building and partnerships over time.
I think for me, it's just that need for creativity. Like we have had to be more innovative in the way we do things, and some of the objectives, we had objectives like at the beginning of some of the work we were doing, and then you realize you can't meet them the way they were written, because you can't go to places. You have to do online training, for example. And the importance of flexibility, so that we know that sometimes you can write, you want to do this, but then things, you are not always in charge. And if things change, you don't stop, you have to keep going.
Yeah, I think that between Dr. Kelly and Dr. Quobo, they've covered nearly all of it. I do think that in terms of from the North American side, I think that the pause in travel has been a really great opportunity to sort of re-examine like what can be done virtually, like, and where the best allocation of resources is to do the best good within the partnerships. So I think that, and I don't have really anything else to add from what Dr. Kelly and Dr. Quoba had said beyond that.
Yeah, again, so another general question is that has the pandemic exposed some unknown weaknesses in the healthcare system in Indiana or anywhere you're practicing and caring for patients? and or implementing research?
I think that I guess I'll take this. It was something I had not been aware of that would be an issue in healthcare providing in Indiana was the political, how preventative measures and even the most basic things to be able to help prevent infectious diseases that are clear and known, around the world, hand washing, wearing masks and things. Then how I feel like the pandemic has changed my view of how different cultural beliefs or political views can sort of shape the way that you view preventative health and public health measures. So that was something that I didn't realize. I knew from being a pediatrician and having vaccine hesitancy in some patients and parents that was something to be aware of. But I think that COVID and the misinformation and different things that have come out from that has been really eye-opening to me. And I think it will change the way that I approach, counseling patients and, advocating for public health measures moving forward.
Thank you for that. Other thoughts from panelists?
I think for me, I think the question was specific to Indiana, but I think for Kenya, I think one of the things that we've had to do, especially in delivery of care, is to explore more the use of mobile phones or even Zoom. We had never thought that we can consult when you're in Kenya on phone, and it was very minimal, but that I have been able to even prescribe from my phone and WhatsApp the prescription, and the pharmacists have accepted that has been really interesting, something we had never explored before that. So I think that for me has been exciting.
And maybe just to add on to both of those comments, I think for me, it's just really illustrated that our healthcare resources are limited in any setting. I think in the US, we tend to feel like healthcare personnel and hospital beds and the resources we have are unlimited because we rarely reach the limits of those resources. But that's something we feel more on a daily basis, even not in a pandemic context in Kenya, where the provider to patient ratio is generally high, where our hospital beds are limited. But I think it really, for me, has really emphasized that healthcare and healthcare personnel and resources are limited in any setting, and really thinking about planning in a health systems perspective of how to maximize those resources with the population you have, and how do you plan for a pandemic to make those resources help as many people as possible. And that's a huge challenge that I think the pandemic has illustrated all over the world.
Great, thank you for that. And one more general question before I go to have you each talk about your own research in a little more depth, is about what you think the most urgent issues and concerns are that need to be addressed in wherever you are practicing currently from a public health perspective.
I think for me, especially in the area of mental illness, is the issue of stigma and awareness. Just people don't even, it's one thing to train people and to increase resources for mental health care. But what I have come to realize is that many people, even very educated ones, still don't recognize mental illness as an issue. And so they don't expect that they should be seeking care, especially in a hospital, except someone does something very, very strange. And it's surprising that even very educated people still don't recognize mental illness as an issue. And so we have a lot of work to do to educate the public about what it is and why they need to seek care, and that help is available.
Other members?
I think that, one thing that has come to mind during the pandemic that I think that people have sort of taken for granted is, during this pandemic, we had access to COVID testing at very low cost in the US. And a lot of the service and the vaccines are free whenever we're able to get them. And a lot of these structural things that we're doing for public health that are really helping to reduce cases and to control the pandemic. And I wonder moving forward if people can see the benefits of having this universal system of providing preventative health services for people. And hopefully preventing lots of other both infectious diseases and then and also other chronic diseases as well. And I wonder, I would hope that, you know, the pandemic has taught us how helpful it is to have easy access to those resources for everyone, and the benefits of that for long-term health of a community or country.
Thank you.
Yeah, and I'll just add on to that I agree. I think it's, for me, highlighted the need for more global cooperations and more responsive systems to allow access to preventative and treatment measures more equitably around the world at the same time.
Great. Well, thank you for that. I'll turn now to have each of you talk a little bit about your own ongoing research. Debbie Unger has invited individuals to put in questions for the members into the chat, but I wanted to have a chance to have each of the panelists talk about their own specific research a little bit more, so that you can direct your questions directly to individuals or general questions in the chat after they've had a chance to go through their own descriptions. So I guess we can, in the pattern, start with you, Dr. Kelly, about your work in Kenya, and particularly in Busia County, if you will, in population health.
Sure, thanks, Deb. So I'll start out with a caveat that I'm not sure that I'm a researcher. I consider sort of the work we're doing program implementation with a robust evaluation or implementation science framework around it is the goal. So for the last 2 years, I've been working with the Empath Population Health team, and I co-lead what we call Pillar 2 Health System Strengthening, along with my Moi University collaborators, Dr. Jamil Saeed and Dr. Charity Wamboi, in broadly health system strengthening. And more specifically, the Empath Population Health team has been working on an initiative to pilot innovative universal health coverage program in Busia County, and particularly in one sub-county. And so as part of the universal health coverage, an important component of that is quality health services. And so the challenge we're trying to tackle is, how do you provide and guarantee quality health services in the public sector, where there's so many issues with supply chains and drug stockouts, with issues with lab reagents and lab reagent stockouts, where you have a very limited human resource capacity with far too many healthcare providers for the population. Given all of those limitations in the public sector and the limitations politically, financially with the budget, how do you even attempt to create quality health services? And so the approach we took was to really try to train and mentor providers in quality improvement using really the IHI quality improvement approach, and really build capacity and mentorship for the frontline providers to be able to problem solve in their facility what their main issues were and what their main challenges were, and then create a network of people working together to address similar issues. Within that structure, we've really tried to partner with the Busia County Ministry of Health, with the County Health Management Team, with the National Kenya Ministry of Health as their quality assurance, so that everything we're doing is in line with the Kenyan national government priorities, and with the county government priorities, and working hand in hand to identify individuals within the Ministry of Health that can co-lead and co-implement this with us every step of the way. So it's not just sort of an isolated Empath project that kind of starts and ends with grant funding and then is over.
Henry, how about you?
Yeah, so the work that I am doing in Kenya, I had an NIMH K23 award that was focused on neurodevelopmental screening of children born to mothers with HIV. And so Dr. Ayungu and I have been working in this space for the past few years of evaluating children's development in Kenya. But inevitably, when we were evaluating children and we would find children with who were severely delayed or had disabilities in their development, and I asked Dr. Yungu, what could we do how should we refer them, or what can we do for them? He had offered, some treatment options, but he said that it was really an issue. There are so many complexities within the system that makes it very hard, and the infrastructure for providing care for children with disabilities is also difficult. And so, on this side, we do have this plan of being able to build a neurodevelopmental center within TRH's campus to be able to address some of those issues. But ultimately, what we're needing to have is an intervention that caregivers could be able to provide, specifically for children with autism, communication or behavioral disorders or disabilities, that they could do within the communities, within their households. And whenever we thought about reciprocal innovation and thinking about what we can learn, even in Indiana here, we have autism hubs that have been developed across the state to be able to lower the age of an initial autism diagnosis. They usually previously had been upwards of 4 or 5 years of age when a child would get first diagnosed with autism. And with the implementation of these autism evaluation centers, that's decreased much lower. But in parts of rural Indiana, it's also an issue to have the infrastructure to help care for young children that have disabilities. And really early intervention is the best treatment that we can have to really optimize children's outcomes over the long term. So one of the areas that we're hoping to develop in the future in partnership with some of our child psychiatrists, I know Dr. Kwoba has connected me with Dr. Aisha, and we're developing some caregiver autism training programs that can be implemented, hopefully both in Kenya and in Indiana, to be able to learn from each other, to learn, how the community health worker, the equivalent of that, could help be trained to then train mothers. And we're hoping that will help make services more accessible to people who need them within low resource settings, both in Indiana and in Kenya as well.
Great, thank you. And Dr. Kwoba.
Thank you. So I'll start just with a brief repeat of what I said I am. I said I see myself as a doctor, a teacher, and a researcher. So again, I'll not focus just on research. And of course, as a doctor, I consult for Moi Teaching and Referral Hospital. That's the first thing, and I head the department. But as a researcher, if you like, I'm doing some work since, let me just go back to history a bit. When I joined Moi Teaching and Referral Hospital in 2015, I had not been involved in research. And then I learned that there was AMPATH, and I met Adrian Gardner, I met Mamlin, and they said, oh, you can participate in some work. And just around that time, I was lucky to get a Fogarty fellowship, which was actually my first main research. And it was a baseline study about the prevalence of mental health in Western Kenya, and we did this in Nandi County. And I remember Mamlin asking me, so what, now that we know the numbers, what can we do about increasing access to care? And most of you will know that one of the challenges we have in our setting is that we have very, very few human resource for mental health, and people have to travel long distances. And because AMPATH was already doing some work with HIV and diabetes, and some little work on mental health, of course, the next most important step after that Fogarty study was to ask ourselves, then what can we do to increase access to mental health care within the sites where AMPATH was? So since then, we have been doing, I'd call them a number of things, not one. One is ensuring that we educate the community. And I remember some of the funds we got from Indiana, courtesy of Bob Ainters and Mamlin, was to make sure that we educate people about mental wellness, because in our setting, other than just increasing infrastructure, you need to let them know they are sick and they can seek care. So we talk to anyone who cares to listen to us, whether it's in a church or a school or in a public gathering. And most recently, it's been very exciting to even just teach the police officers about mental health. So one, we educate the community. The second other thing that we do is we do capacity building, and we wouldn't go back into the details of these limited resources, but then the question is, then what do you do? And we know that nurses, clinic officers are taking care of diabetes, they're taking care of hypertension. And one of the things we've been doing within the AMPATH infrastructure is also increase capacity for the nurses, for the clinic officers to recognize mental illness. And we do very brief trainings on using the WHO, we call it the MH gap, the mental health gap intervention guide, and just teach them basics of what depression looks like, what alcohol use disorder looks like, and help them to be able to recognize and initiate care for the patients, noting, of course, that there are some who require to be referred to higher levels. So capacity building, and we've actually trained more than 200 healthcare workers since that time when we started, of course, for different fundings. There was the Indiana University Fund, and then currently we are funded by Astellas Global Health Foundation. So after capacity building, we also do community screening because we know that most of these people will not seek care. So we initially, when we started in 2016 within Nandi County, we used to use community health volunteers to screen, but going forward, we've also had like other nurses and psychologists be able to train. And we have actually screened, at least within the community, more than 14,000 Kenyans within Western Kenya, and have been able to link some of those to healthcare facilities, different healthcare facilities. Some we are following and some we just link them to care. And one of the most exciting bits of that piece of work is the issue of alcohol and substance use disorders, recognizing the gaps that there are within Kenya for rehabilitation centers. We have set up alcohol support groups for those who are affected. And one of the best stories to listen to when you hear a woman saying, I could not afford to go to a rehabilitation center, but because you brought the alcohol support group within the community, I've been able to take care of my children. Or someone, I remember one of the funny stories, well, not very funny, but yeah, it was interesting to interact with, was a man sleeping on the floor because the whole time he used to be drunk and he'll come home and he didn't have a bed. And I remember we actually contributed money to get him a bed when he realized it was not very good for him to sleep on a bed after he became so of these community groups. And we actually have more than 900 members of the community who have alcohol use support group, who has alcohol use, and we have been them to groups. We have at least about 50 groups within the community, one very, very exciting aspect of care. And most recently, one of the things we've been doing with Matthew Turisini and basically with Indiana is the funding from Astellas Global Health Foundation that expanded the work that we are doing in terms of education, screening, but we also were able to set up within the Moi Teaching and Referral Hospital campus the first transitional home for mentally ill patients. We call it Nawiri Recovery and Skills Center. And the exciting bit, other than being the first one in Kenya, is that we are not just accommodating them, we're actually building vocational skills. Of course, this is work in progress, very recent, just started recently. It was actually opened officially on the 26th of August this year, and we are looking forward to growing it and making sure that at the end of the day, there are lessons for us and for people out there to know what we can do within our setting. To not only, we are doing two things. We are training illness management and recovery. Is a program actually that was shared with us by a team from Indiana. There's Angela Rollins, she's a psychologist who actually helped us start that. And we're also doing basic skills like beadwork and basketing. So that's so much for care. And then, of course, the other thing that we are doing is research. And other than the Fogarty study, I'm working with Kara, Wools, and other team members within IDEA on HIV, how the mental health interacts with HIV, and there are several studies that are ongoing. I'm also participating in a study by Lukoya Tuoli on NeuroGap, the genetics of mental health. And even us as a team, we call ourselves the mental health team that has now, that quote unquote, now I lead. Most of the others have been working with people. We have been trying to do small studies within the care programs. Like one, we have alcohol support groups, but how do you even evaluate and know whether it works? So we actually did an objective evaluation of that, and we are hoping that will be published. We sent out the manuscript. We also don't know that there's any documentation of the mental health system that exists in Kenya. That's a study that we are doing, and several others that are in the tray coming. And I'm excited and hopeful that I can apply for a grant on my own. There's the R01 for early career researchers by the National Institute of Mental Health, and I want to give it a try. Even if the chances, whatever the chances are, I want to give it a try in the journey of becoming an independent researcher. So that's so much for myself. Thank you.
Thank you, Dr. Koba. Well, we wonder if you ever get any sleep here, but we know you're speaking to the right group. With Dr. Glass just talked about all those grant opportunities for our stars that are emerging and have emerged internationally. We count you in that group, Koba. An added on question to all the wonderful information you just shared. I know that you were a recipient of one of the CTSI's reciprocal innovation grants in collaboration with Dr. Tierney. Is some of the work you just described part of that, or is that something in addition?
Yeah, yes. So that's in addition to the many other things that we are doing. So the CTSI grant we got this year is of course we have been doing community education, we've been doing screening, but one of the things that we realize is that we are focused on general adults, and we realize we haven't done so much for the youth. So this exciting project that we are truly grateful to have an opportunity to work on is going to focus specifically on the youth within a community facility within Eldoret. And one of the things we are going to do is we are going to train peer youth to be able to screen for mental illness within the community facility. And we are going to also train them to do something very simple, problem-solving therapy. I'm sure for those of you who may have read the friendship bench that Dr. Rogers actually described, it's actually problem-solving therapy, and it's been shown to take care of many forms of mental illness. So we actually want to teach those youth to administer 6 sessions of problem-solving therapy within that community group, and see whether they can actually be useful in reducing the issues of depression, and other secondary things will be anxiety and depression and alcohol use disorders. So yes, very exciting project. We are just in the process of preparing for that. We just got our approval from Moi, and I know we are waiting for approval from Indiana. And we also got the NACOSTI, the national one. So we'll be rolling it out. We have the starting date as January. And I'm sure in the next meeting, maybe next year, we might be giving you feedback of such things, how they turned out. And we believe it will be positive.
Excellent. Thank you so much. And in the spirit of all of us trying to really understand reciprocal innovation, what is the arm that impacts Indiana in your reciprocal innovation grant, or at least the hoped for impact for Indiana?
So one of the things we believe, as much as of course in our setting, maybe they are more limited. There's more limitation for human resources, more stigma for mental health. The truth of the matter is that stigma, limited human resource, cuts across the globe for mental health, and like for all other illnesses. So we believe that if we're able to demonstrate that youth can actually be useful in reaching out to their peers within Eldoret, it would also apply in a setting even within US, that youth can actually be useful in reaching out to their very own, and that they can be able to even do simple interventions. So we don't think that this intervention is very specific for persons in Eldoret. It's also possible that this can be applied both in Indiana and any other parts of US, or any other developed state for that matter.
Great, thank you so much. And Dr. McHenry, I'll turn to you here before I turn to the questions in the chat box for all of you. But if you would also care to comment, you're also the recipient of one of the reciprocal innovation grants, I believe. If you would speak to that a little bit.
Yeah, the reciprocal innovation grant that we have is a planning grant. So we're doing lots of planning of that now, but the plan is for the intervention that I had mentioned previously that would be focused on helping to train caregivers of children with autism or communication and behavior challenges to be able to work with their children and understand their children a little bit better. To be able to help provide the support that they need and may not be able to get in like applied behavioral analysis, which is ABA therapy, the standard, like gold standard treatment for autism in the United States. ABA therapy is fantastic and has been shown to have good results for children, but it's oftentimes only available or only readily available in settings like in larger urban centers in the United States, or in Nairobi they have it, but only for very private, very expensive services. And so the hope is that we could have a community-based personnel. So in Kenya, it would be community health workers, and then and similar cadre of individuals in Indiana that would be able to learn how to train people on this curriculum, and that we would be developing it primarily in Kenya, to sort of understand what are restraints that you might have if you're like worried about taking care of other children, or like the stresses of trying to find like enough money and resources for food and school and everything like that for your children, and sort of figuring out what elements are really key in being most helpful and beneficial for caregivers there, and then seeing if those same principles would be applicable here in Indiana too. And so our hope is within the planning grant we're having, Dr. Aisha, one of the psychiatrists at Moy, we'll have Dr. Erin Ayungu, we'll have another pediatrician, Dr. Barnabas Keegan, and then the OT. A lot of the children in Kenya are getting OT therapy for autism and other behavioral issues. And so they're coming to Indiana to see different ABA centers and other treatment things, to see like what elements of that would resonate and work well in Kenya. And then we're hoping that we would be able to create an intervention that we could then implement in the upcoming year or two.
Wonderful, thank you. Well, let me try to systematically go through some of the questions that came in the order that they came in. I have a question from Tommy Soares about inequitable responsibilities of mothers versus fathers during the pandemic with e-learning schooling. He is asking for you to comment on that. Some smiles.
I think Dr. Kwoba, I know that she has more children than I do, but I could only imagine the challenge. I think generally she could speak to that better than me, but I think the challenges are universal.
Yeah, so I think it's complex. First, like in our setting, I think it was always the woman doing a little more. And so what happened in the context of pandemic is the woman continuing to do a little more. And of course, it's biased because that's the experience I have. But what we have seen, especially with like Zoom classes, because at one point, like us, we had to do Zoom classes, then there was a need for fathers to do a little more. The other thing that we saw, like in our setting, is that some fathers actually had to work from home. You know, traditionally, the father always went away, but sometimes now they had to work from home because of the COVID. And we saw some slight change because now the father was home, and they were home when maybe it was mealtime, and there was a slight increase. Of course, as scientists, we can't say objectively that we know for sure there was improvement in terms of participation, but just anecdotal and from indications is that there was a slight improvement in the participation of fathers, especially because some of them had to be in the house a little more than previously, and the fact that children needed to be guided with Zoom classes. But I still think it's not fair in traditions where the woman always did more, but we are hoping that can change over time. But maybe the pandemic didn't just bring like an overhaul and change everything.
Yeah, I feel like this question, you'd have like a whole hour conversation about the inequity and the responsibilities between mothers and fathers. And I think it's, I don't know, I feel like I give an unbalanced and maybe biased perspective as a mother. But I do think that both in Indiana and in other places around the world, I'm sure that the pandemic has really exposed some of like individual household responsibilities of caregivers. And who those lead to. So I'm not sure if there was, in terms of reciprocal innovation, if there was a specific focus that we should be focusing on for that question. But I do think that the pandemic has probably only worsened any inequities and responsibilities in caretaking and schooling. And certainly for children with disabilities and not being able to, oftentimes with the virtual school, a lot of children who are going to school to get some therapies and stuff, that was a huge challenge during the pandemic, certainly, and that the burden of trying to facilitate therapies or getting things done virtually oftentimes did fall onto the mom or whoever was taking care of the child at home.
No, thank you for that good question, Tommy. I'll move on to another question. I think a very practical question asked by an anonymous person here. Again, is when each of you are talking to a family or friends who may not really completely understand your work, how do you describe in a way they can understand the importance of your global health collaborations?
I don't know that for me, I could start, and I don't know that it's that complex for me, because I let them know that I have some knowledge and other people have probably resources. And so it becomes easier to say we need to partner so that we can combine the knowledge and the resources and the different experiences that we have. So especially like for me, it's a lot of concern because most of the meetings we do with my collaborators come at 4 p.m. and 4 p.m. is family time. So it's not a very uncommon question, but I have to keep explaining that some of the things we do, we have to do with people who are not here. And why do we have to do with people who are not here? It's because we have different resources and experiences. Of course, sometimes it's especially in our culture where people are concerned, why do you really need to work with Muzungus? And is it not colonization? Sometimes that is a very common question, and whether you think you're giving data out there. And I think it's a justified question because maybe it's from where they come from, but I think just explaining that where I come from, I'm not coming from a position of feeling like I want to sell data to someone. I come from a position of I want to make a difference in mental health. And what do I need? I need resources. I need people who have different experiences. And that happens to be people from a different world. So I hope that answers the question. So it's not very simple, and sometimes it's complex, and sometimes people are paranoid about different things. But I think it's calls upon us first to be clear about what we are doing so that we can be able to explain to others.
Yeah, no, thank you for that.
Yeah, Dr. Kova, I really liked listening to your answer. It's good to get that perspective. Because, from my end in collaborating with Dr. Yungu and others, it's the thing that I feel like I learned so much from their experiences and having to be really creative and troubleshooting whenever challenges faced by the issues with infrastructure that happen within the Kenyan medical system that we also mirrors like issues that we have also in Indiana as well. And so I feel like the work that I do in childhood disabilities is really accessible for most of my family and friends. Like people understand, the challenges in getting services for children with disabilities. But I think that in thinking about global health and why it's important to collaborate is that I've just learned a lot about how to reach families and how to do it in a very thoughtful way, and doing it and meeting them where they are and being able to help them advance care for their children and within whatever resource constraints that they have. I think that I've learned a lot from Dr. Yungu from that. And so I think that doing it and learning from our partners in Kenya and doing that will help me do it better in Indiana as well. And so I'm grateful that he's been so gracious with his mentorship in that way for me.
Yeah, I would just, I was just going to agree with both Dr. Kwoba and Dr. McHenry, and that I feel so privileged to have the opportunity to work with my collaborators at Moore University. And I think really in all of the different projects I've worked on, everyone comes from a little bit of different experience and background and training. And you really have a lot of growth in everyone sort of bringing different ideas and perspectives to the table. It's really been an amazing learning experience, and not only from the individual partnerships, but also in sort of being exposed to and learning a whole different health system, because the Kenyan health system and the public infrastructure for health here is so different than the US. I think that there's a lot of lessons learned there for us as well, thinking on the health systems level.
Great, thank you. Another question from Chris Longnecker. Reciprocal innovation may be facilitated by funding researchers and trainees from other countries to do research in the US, but there are significant barriers. How can we promote research flows from low and middle income countries to US for projects with explicit reciprocal innovation aims?
I guess I'll start. That's a tough question. For me, I think that's really comes down to funding. I think the main barrier to supporting more research for investigators for low middle income countries coming to the US is a funding challenge. And so I guess the way Empath has approached it is asking for commitment from institutions and universities, and committing by engaging in this partnership. They also commit to fostering bilateral partnership and training. And there's a financial expectation with that because we all know that travel and all of those aspects cost money. And so I would say kind of promoting partnerships with clear obligations for bilateral support and funding to back that up is a good start. And I think the Empath model is a great one and could be shared because I know not all partnerships have equal expectation of supporting partners' travel, research, training in high-income countries.
And, I think that I agree with exactly what Dr. Kelly was saying. I also, to add on to that, I think that, in the partnership that I've had with my colleagues in Kenya, I realized that, and I think a key aspect of reciprocal innovation, as what was presented earlier, is, you really want to have mutual benefits and a really equitable partnership, and you might not do equal work, but I think that each of the partners can bring their strengths to the table to be able to work together to get sort of the end product together. And something that I've just personally done in my own research is, Dr. Ayungu and the other collaborators I have really amazing ideas that I think would yield useful data and information to help in Kenya and then also in Indiana. But they don't have protected time like I do to be able to write up these research grants or to really to spend a lot of time. So I think that by us for having their ideas and helping to support them and developing those so that we can collaborate together and work on projects, I think is a way that we can use each of our strengths and to be able to really, I think it's the responsibility of some of the North American partners at times to be able to really make sure that the questions and the ideas that our partners have are really the focus of what we're doing, and we're really prioritizing the needs that are identified locally and being able to help support them in putting grant applications together, and then in also training and mentoring more junior faculty or trainees in Kenya too to be able to do this work, I think is a way that we can help promote the flow of research and reciprocal innovation from LMICs to the US.
I think the only addition, and probably because now a lot of times is maybe we are thinking about LMIC to US, but I think thinking about collaborations and how peaceful or less conflicting they can be from the word go is to clarify what the goal of the collaboration is about, just from the word go, so that people don't have to be paranoid about why we are doing what we are doing and where we are going. Just have a clear vision together, and that should be clarified from the word go when you're collaborating, so that people don't feel like they've just been brought in the middle of something and expected to carry on, but it's not very clear where we are going. So I think just involving the partners early on clarifies issues better, I think.
Great, thank you, ladies, for that. The next question is addressed to me. I've been trying to hold back about myself or my research, but thank you for the question. This one was directed asking me to elaborate on my shifting of global to local experience in Indiana with the We Care program, and recommendations that I might have for young global health investigators in identifying community and public health partners. So I could talk all hour about this, but my work in We Care has been to reduce infant mortality in Indiana, where our numbers are abysmally high for our entire state, with its ranking as about 43rd out of 50, and in particular for our Black infants, which are 2 to 3 times higher than our white infants. So it was really inspired by work that I did with one of my own mentees from our D43 training grant through Fogarty many years ago in Kenya, where my mentee was working in the non-DT estates on a maternal child health project where they very effectively and efficiently employed and deployed and trained community health workers, volunteers. And it was very clear that addressing the mutable, modifiable risk factors for infant mortality can be clearly done by a well-trained, well-supervised lay workforce with boots on the ground that have credibility within their own villages or their own towns, can make a huge impact. And so that model is what we exported here to Indiana to try to impact our own health outcomes for infants and mothers here in Indiana. And over 5 years of funding, we have now accrued sufficient data to demonstrate that this highly effective community health worker workforce is improving all of the major risk factors for infant mortality. We have improved low birth weights. We have decreased infant mortality rates, particularly in our Black infants in Indiana. So what would I tell a young global health investigator is that, we listen and we learn across the world to all of the challenges. Take on big challenges. It's worth it because, to be able to say that we've saved, one baby anywhere in the world, one mother anywhere in the world is well worth it. It takes perseverance and it takes creativity, and it's the loop of making the world much smaller by working together with our colleagues. So it's been a fabulous opportunity. I've learned a lot from my own mentee, Betsy Rono, and will continue the work as long as I can. So I think we will close. We're at 9:50, which was the time for closing. On that note, thank you so much for the panelists. Dr. Kelly, Dr. McHenry, Dr. Kwoba, thank you for your amazing work. You are an inspiration to me and to, I hope, others on the call today. Thank you, Dr. Glass, for heading us out with your wonderful talk to get us inspired to do more work in reciprocal innovation and global health work. I'll turn it back to you, Bill.
There we go. Well, thanks so much, Deb, and for your panel. It's both inspiring and kind of awesome to see what just individual people can do when they work as large integrated teams across sometimes long distances and very big cultural, language, and other differences, that those barriers can be overcome to do pretty amazing reciprocal innovation research. We have a few minutes for people who have kind of generic questions about reciprocal innovation. I'll remind you that the Indiana Clinical and Translational Sciences Institute has a formal reciprocal innovation program that funds $10,000 planning grants and up to $50,000 pilot studies that lead on to either projects that can be implemented or go after larger funding. I believe the funding cycle is done for this year. Then it will open again in July of next year. But they've handed out more than $600,000 worth of funding to this point. You've heard about some of those projects today. I would encourage you, those of you who might have some interest in this, to go to the website and look at the kinds of things that have been funded to investigators. It has to involve a CTSI investigator and a partner from a low and middle income country, not just AMPATH Kenya. But there has to be an investigator from either IU, Purdue, or Notre Dame. But you can see who at those institutions have done what, and if you have an interest in you figure you might learn from what they've done or what they are doing, have a low threshold for pinging them and just say, "Can I talk to you about this? Because I have an idea." Or you can ping me or Deb or any of the faculty on this over the past couple of days and ask us, and we can make sure that your question goes to the appropriate person. But the idea is to stimulate these types of activities. And we have a platform now for doing that, both in AMPATH and also the AMPATH replications in Ghana and in Mexico, for those of you who might have interest in those areas. But there is a platform for doing this. And I would hope that those of you with great ideas would would see this as an opportunity to get to jump in with both feet. Are there, I guess, because you're all muted, are there questions? If you have questions, you can go ahead and enter into the Q&A, and I'll wait a couple of seconds to see if anything comes there. If not, then we can close it a few minutes early and let you all get on to your next event for the day.
Bill, I just want to clarify that the planning grants are closed until July of 2022. However, the implementation grants, the RFA will be going out in the next 1 to 2 months for submission in the spring, and then review next year.
Actually, you mentioned that yesterday and I forgot it. So I appreciate your weighing in on that, Kara. That's perfect. So again, if you have an interest, please apply. I mean, I'm on, Kara and I are both on the review committee for those grants. So we would love to have the problem of too many good fundable things. So please, if you have ideas, float them, ask people for advice, etc. But we would love to encourage people to apply to the implementation grant cycle when it happens. I guess the deadline is February or March, somewhere in there, but certainly the RFA is going to come out in the next month or so.
Bill, I see a question about hearing more about AMPA's application in Ghana.
Oh, okay. Is Raj on today? I guess Raj, he's going to be muted anyway. The AMPATH is being implemented in 2 and maybe 3 places: Ghana, Mexico, and perhaps Nepal. They have some discussions with Rachel Vreeman and Mount Sinai, who has a collaboration with a university in Kathmandu. But NYU, it's they have the Global Health Center within the Department of Population Health, has a relationship with the university in Tamale, Ghana, and they are on. I don't know if they have boots on the ground now because of COVID. If not, they will very soon. But they've been up and running for about a year now, and have identified collaborators on both sites in all 3 missions of care, teaching, and research. The leader of that collaboration is Raj Vedanthan, and if you can ping anyone on this call who've been leading this conference, can connect you with Raj if you have an interest in what's happening there. They're just ramping up, so obviously they're focusing mostly on doing a research needs assessment and identifying people who'll be leading different parts of it. But if you have an interest in perhaps getting involved in Ghana, I'm sure they would be willing to have in-depth discussions. Same thing with Mexico. There are already several universities who are in discussion with Tim Mercer at the Dell Medical School and the University of Texas at Austin, who are in the process of developing a AMPATH model with university in Puebla, Mexico. Again, COVID has slowed this down a lot, but not entirely. The team leader for Mexico has been hired, is actually in Mexico as we speak. So those programs are ramping up, and if you're interested in either one, let us know and we can make the connections. I should mention that Raj Vedanthan spent a year in the aughts, 2000 and aughts, as the team leader, the medicine team leader in Kenya. So he got his initial feet wet there and has now gone on to be a global health leader at NYU in Ghana. Any other questions? Okay, we're at time. I really appreciate everyone's participation today. I hope you are as excited about what we heard as I have been, and are encouraged to make reciprocal innovation a focus of at least a focus of your research activities. I want to thank Rish O'Brien and Michael Scanlon for the amazing work they did in setting up these 2 days. These things don't happen spontaneously, and I'm so happy that that it's come off with reasonable, always some technical glitches, but it came off reasonably well. And I want to really thank the presenters today, especially Roger and our panel, for the remarkable information we gather and hopefully the inspiration that we take forward. Thanks everyone for